Welcome at vpod.ai, where we take a deep dive into complex topics, really extracting the most important nuggets of knowledge and insight to keep you well informed. Today's deep dive is sponsored by Stonefly. They're your trusted solution provider and advisor in enterprise storage, backup disaster recovery, hyper-converged VMware, Hyper-V, Proxmox cluster, AI servers, SA365, which is a turnkey security appliance, and also public and private cloud solutions. For more information, definitely check out stonefly.com. So today we're embarking on a really crucial deep dive. We're looking at stomach cancer, sometimes called gastric cancer. Our mission for you is simple. Cut through the noise. We want you to really understand the symptoms, the risk factors, the latest treatment approaches, and the absolutely vital roles of nutrition and palliative care. We're sifting through quite a bit of information here, aiming to separate, common myths from some surprising facts and equip you with actionable knowledge about this disease that's often misunderstood. So let's get started. Let's unpack this.
Yeah, it's definitely a topic that demands our attention. I mean, globally, stomach cancer is the fifth most common cancer.
Fifth? Wow.
Yeah, and tragically, it's the third leading cause of cancer-related death worldwide. What's particularly striking, though, is how much the incidence varies around the globe. It's not the same everywhere.
That's a really key point, because while it's a major concern in places like East Asia, Western Asia, Eastern Europe, South America, the picture here in the U.S. is, well, surprisingly different. We've actually seen new cases decline about 1.5% annually over the last decade.
It's true. And that's likely thanks to advancements in, technology and scientific research here.
A real testament, yeah.
It really is. And generally, it tends to affect older individuals. The average age of diagnosis is around 68.
Okay.
And nearly 60% of cases are in patients over 65.
Yeah.
It's also almost twice as common in males compared to females.
But you mentioned a nuance there.
Well, yes, there's an interesting trend emerging. We're seeing rates actually increase in younger females, particularly Hispanic females, right here in the U.S.
Sure.
And that really highlights the need for more targeted research into why that demographic shift is happening.
That's certainly something to keep an eye on. But okay, here's where understanding this disease gets tricky and, frankly, a bit deceptive. The early symptoms.
Right.
Many people, they don't experience any symptoms at all until the disease is quite advanced. And when those early signs do appear, they often mimic common, less serious things, like everyday indigestion or acid reflux.
Exactly. It's so easy to just shrug them off, isn't it?
Yeah.
Thinking, oh, I ate too much, or that just didn't agree with me.
Yeah.
And that is the absolutely critical message for you listening. Anything that feels different, something that changes and persists for more than, say, 2 or 3 weeks, it really needs to be checked out by a doctor.
The stories from survivors really drive this home, how misleading these signs can be.
They really do.
Take Janine Soma. She was just 28 when she was diagnosed. She described this burning, gnawing pain in the center of my stomach. Initially, her doctor just said it was acid reflux.
Just 28. And Erica Hunkin, 35, she had these really weird abdominal pains that stretched up and across my chest. She actually thought it was her heart. Then there's Craig Galati, 62. He suddenly developed really bad heartburn after eating almost anything, which was totally unusual for him. Plus, this weird hiccup thing after eating too much.
And what did they find?
A golf ball-sized tumor right near the top of his stomach.
Yeah.
It just shows how subtle the body's signals can sometimes be.
And fatigue, that can be another huge indicator that's so easily missed.
Absolutely huge. Sylvia Coe, 54, she just put her extreme fatigue, shortness of breath, dizziness. She put it all down to stress until she literally swooned in a restaurant.
Oh, my goodness.
And that led to discovering a heavily bleeding tumor. Ralph Luja, 57, his fatigue was so bad he couldn't even climb stairs. The cause: severe anemia, blood loss from a tumor he didn't know he had.
Incredible.
Even something seemingly minor, like unusual hunger pangs. Dr. Joe Einspar, a hospitalist, 55 years old. He felt hungry, even though I knew I shouldn't be. Just this nagging sensation that eating didn't fix, especially during quiet times between his shifts.
So these stories, they really paint a picture of symptoms that are, well, easy to overlook, but absolutely vital to recognize if they're persistent and unusual for you.
Precisely.
Okay, so if these subtle signs are easy to dismiss, what are the absolute red flags, the non-negotiables that mean get medical attention now, even if they seem subtle at first?
Great question. These are the ones where you absolutely need to see a doctor right away.
Right.
Any amount of vomiting blood. Period.
Any amount. Okay.
Bloody stools, often described as looking black or tarry. They might even smell kind of like steel or metal.
Right.
Or severe abdominal pain, like an 8, 9, or 10 on a 1 to 10 pain scale.
And I guess if you suddenly can't keep anything down or, you vomit food you ate days ago.
Exactly. That's another critical sign. It could signal an obstruction, some kind of blockage. And that definitely requires immediate medical attention. It really just emphasizes how important it is to listen to your body when something changes and doesn't go away.
Let's turn our attention now to the risk factors. Understanding how this disease typically develops seems really key for prevention.
It is. And it's important to know this isn't usually something that happens overnight. Stomach cancer typically develops slowly, often over many years.
How does it start?
It usually starts with small changes in the DNA of stomach cells. These changes cause the cells to multiply too much, forming these abnormal growths we call tumors.
And what's really interesting here is the role infections can play. You mentioned H. pylori.
Yes, Helicobacter pylori, or H. pylori. It's a chronic bacterial infection, and it's a major risk factor. It's strongly linked not just to stomach carcinoma, but also a type of stomach lymphoma called Malt-on lymphoma.
How does it spread? Is it common?
It's very common, actually. It spreads person to person through saliva, vomit, or stool. Many people who are infected have zero symptoms. But it can lead to stomach ulcers or a condition called atrophic gastritis, which is a thinning of the stomach lining.
And it's classified as a carcinogen.
It is. The International Agency for Research on Cancer classifies H. pylori as a Group 1 human carcinogen. That means it's a definite cause of cancer. The good news, though, is that treating the infection, testing for it, and treating it significantly reduces the risk of developing stomach cancer later.
That's a huge takeaway for prevention right there. Are there other infections involved?
Epstein-Barr virus infection is also linked. And then, of course, there's diet. That plays a really significant role.
Right. What kind of dietary habits increase risk?
Diets that are low in fruits and vegetables, especially colorful ones, or diets high in salted, smoked, or poorly preserved foods. Think heavily salted fish or meats, pickled vegetables. Those sorts of things are associated with higher risk.
Okay, so on the flip side, what dietary choices might help reduce the risk?
Things like getting enough vitamin C, eating whole grains, carotenoids. Those are the pigments in colorful veggies like carrots and squash, brown onions, allium compounds found in garlic and onions, and even green tea. These are all associated with a reduced risk. Now, we don't have definitive randomized trials proving causation for all of these.
Right, correlation isn't causation.
Exactly. But the association is strong enough that focusing on these foods is generally seen as beneficial.
Makes sense. What about lifestyle factors? Smoking must be on the list.
Oh, absolutely. Smoking is a major behavioral risk factor. It nearly doubles your risk of stomach cancer.
Yeah.
And interestingly, it also makes H. pylori treatment less effective.
But quitting helps.
Yes, quitting smoking definitely lowers the risk over time. It's a crucial step.
Okay. What else?
Obesity. Excess body weight is linked to increased risk, particularly for cancers in the upper part of the stomach, near the esophagus. And managing alcohol consumption is another factor in mitigating risk.
So lifestyle, diet, infections. What about underlying medical conditions? Can they increase susceptibility?
Yes, definitely. Certain conditions significantly impact risk. Chronic atrophic gastritis, that thinning of the stomach lining we mentioned, or something called intestinal metaplasia. That's where the cells lining the stomach start to look more like intestinal cells. Both are big risk factors.
And others.
Pernicious anemia, which is an autoimmune condition affecting vitamin B12 absorption. Also, GERD, gastroesophageal reflux disease. That constant backwash of stomach acid into the esophagus increases risk, especially for those upper stomach cancers.
What about things like stomach polyps, or even common medications like PPIs?
Stomach polyps, yes, while often non-cancerous, can sometimes increase risk depending on the type. And there is some evolving research that's a bit complex, suggesting a possible link between long-term use of proton pump inhibitors, or PPIs, and gastric cancer risk, particularly after successful H. pylori treatment. But confounding factors are hard to rule out completely there. More research is needed.
Okay. And I imagine genetics must play a part too. Family history.
Absolutely. Having a first-degree relative, so a parent, sibling, or child with stomach cancer, does increase your risk. And there are specific inheriting cancer syndromes, things like familial adenomatous polyposis, hereditary diffuse gastric cancer, Lynch syndrome. These carry a significantly higher risk.
Interesting. Even blood type.
Yes. Having type A blood has been noted as a minor risk factor as well. And then there are environmental or occupational exposures, workers in industries like rubber or coal, or people exposed to very high levels of radiation.
Okay, wow. So after covering all those risk factors, which can feel a bit overwhelming, what's the empowering message here? What can you actually do for prevention?
Right. It's important not to feel helpless. The power of prevention is substantial, and there are actionable steps. Focus on eating plenty of colorful fruits and vegetables every day. Try to reduce your intake of those salty and smoked foods we talked about.
And smoking.
If you smoke, stopping is probably one of the single most impactful things you can do for your overall health, including lowering this risk. And critically, talk to your doctor about your family history. If you have a strong history, screening might be an option to discuss.
And that H. pylori treatment.
Absolutely key. Eradication therapies, often involving antibiotics like amoxicillin plus a PPI like omeprazole, have shown really significant long-term reductions in both getting gastric cancer and dying from it. It's about taking those proactive steps where you can.
Okay, let's shift gears now. Let's talk about life after a gastrectomy. The surgical removal of part or all of the stomach. That's a profound change for the body, isn't it? Nutrition must become incredibly important.
It's absolutely central. You know, getting adequate nutrition before the surgery is vital too. It helps prevent deficiencies, maintain strength and weight, boosts your ability to fight infection, can reduce side effects from other treatments, and really aids healing afterwards.
And after the surgery.
After surgery, the way you digest food changes fundamentally. Food might move much faster through your system, and your ability to absorb nutrients becomes less efficient. This really highlights why a careful, thoughtful adaptation to new eating habits is just so crucial.
So what does that adaptation actually look like in terms of everyday eating? What are the key strategies?
Well, the primary strategy is moving to smaller, more frequent meals. So instead of 3 large meals a day, the goal is more like 6 or more small meals. Or maybe even thinking about it as a half-size meal every 2 to 3 hours.
So structure becomes important.
Very important. Creating and sticking to a meal schedule is key, not waiting until you're starving. And importantly, finishing that last meal at least 2 hours before you go to bed.
So it's not just what you eat, but very much how you eat.
Exactly. Eating mindfully is crucial. Eating slowly, putting your fork down between bites, chewing food really well into very small pieces to help digestion, and staying upright, sitting up straight during the meal and for at least an hour afterwards. That helps too.
That makes a lot of sense. What about liquids? How do you manage drinking around these smaller meals?
That's a really good point. You generally want to limit liquids with your meals, maybe to about 4 ounces, half a cup or so. This helps avoid feeling too full too quickly, and it prevents food from rushing into the small intestine too fast.
So drink liquids between meals.
Yes, exactly. Aim for your total daily fluid intake, maybe 8 to 10 glasses, but drink most of it at least an hour before or an hour after your meals. And it's usually best to avoid carbonated drinks if they cause fullness or discomfort.
What about nutritional priorities, especially for healing right after surgery?
Protein becomes absolutely top priority for healing and recovery. You need good sources with each meal. Think meat, chicken, fish, low-fat dairy, eggs, tofu, nuts, nut butters.
Got it. And food choices generally. What's easiest initially?
Initially, it's best to opt for soft, well-cooked foods. Things like peeled zucchini, smooth tomato sauce, bananas, applesauce, cooked cereals like oatmeal, mashed potatoes. You might find it best to avoid raw vegetables, tough meats, spicy foods, peppery foods, fatty foods, and sugary foods at first, especially if they cause discomfort. You reintroduce things gradually.
One challenge patients often face is something called dumping syndrome. Can you explain what that is and how it's managed?
Yeah, dumping syndrome is essentially a sugar intolerance. It can cause symptoms like cramping, stomach pain, or diarrhea pretty quickly, maybe within 20 minutes of eating sugary foods.
That sounds unpleasant.
It can be. And sometimes, about an hour or two later, you might get other symptoms like weakness, hunger, nausea, anxiety, shakiness, maybe sweating. That's often due to a rapid drop in blood sugar because the body released too much insulin in response to the sugar rush.
So how do you manage it? Avoid sugar.
Pretty much. You need to avoid high sugar items, sodas, fruit juices, candy, honey, syrups, cakes, cookies. Focusing on those smaller meals with good protein content really helps, and including soluble fiber found in foods like canned fruits, bananas, peanut butter, oatmeal can also help manage it.
Are there other common food intolerances that might develop after this surgery?
Yes, fat intolerance is another common one. The signs are usually changes in bowel movements. Maybe they're frequent, floating, light-colored, frothy, greasy, or particularly foul-smelling. That can indicate poor fat absorption.
And the approach there?
Start with very small amounts of fats and gradually increase as tolerated. Listen to your body. Lactose intolerance can also become an issue or worsen if it was already there.
So gas, bloating, diarrhea after dairy.
Exactly. Usually 30 minutes to 2 hours after having milk or ice cream, for example.
Mm.
Again, the strategy is slow reintroduction. Start with tiny amounts. Hard cheeses and yogurt generally have less lactose than milk or ice cream, so they might be better tolerated. And there are always lactase supplements or lactose-free dairy products available too.
Okay, so with all these adjustments needed, what are some practical tips for daily living? How can you make this new routine easier?
That's a great question because it can feel overwhelming. Keeping your favorite, easy-to-eat foods readily available is smart. Cooking in batches and freezing leftovers can be a lifesaver on tired days.
Little things help.
They really do. Using small plates can make meals seem less daunting visually. And tracking your food intake and weight regularly is really important. It helps you and your healthcare team monitor your nutritional status and make sure you're getting enough.
And managing those lingering symptoms like nausea or reflux. Any tips there?
Yeah, for nausea, avoiding rich, spicy, or greasy foods helps. Eating slowly, chewing really well, and not lying down flat right after meals are key. For reflux, definitely sit upright during and after meals. Wear loose clothing around your waist. Eat or drink at least 2 hours before bedtime. And using a wedge pillow to elevate your head and shoulders in bed can make a big difference.
That leads me to think about eating out, socializing.
Yeah.
How do you navigate restaurant meals with these guidelines?
It definitely requires some planning and adaptation. Restaurant portions are usually huge, right?
Oh, yeah.
So consider splitting an entree with someone, or ask for a to-go box right when your meal arrives and put half away immediately. Another strategy is to make choices, maybe have an appetizer or a drink or a dessert with your main meal, but probably not all three, to manage fullness. It's truly about adapting to a new normal, finding what works for you, but it's definitely manageable.
Okay, as we transition into discussing advanced care for stomach cancer, one of the most critical aspects, I think, is palliative care. This term often gets misunderstood, doesn't it? People sometimes think it only means end-of-life care.
It absolutely does get misunderstood, and it's so much more than that. Palliative care focuses broadly on preventing and relieving suffering. The main goal is improving the quality of life for patients and their families when they're facing a life-threatening illness. And this can be at any stage of the disease, not just the end.
So for advanced gastric cancer or AGC?
For AGC, a comprehensive multimodal approach is really recommended. That means bringing together a team: surgical, medical, and radiation oncologists, gastroenterologists, and crucially, palliative care specialists. The interventions they provide are specifically designed to relieve those distressing symptoms, like bleeding, obstruction, fluid buildup of sites, and that dramatically improves overall quality of life.
Let's talk about some of those specific symptoms palliative care addresses. Upper gastrointestinal bleeding, for instance. That sounds particularly severe.
It can be very serious. Upper GI bleeding can cause symptoms like dizziness, lightheadedness, even fainting because of low blood pressure. It can absolutely be life-threatening. But the good news is there are quite varied and effective treatment options available now.
What are some of the main ways to control that kind of bleeding?
Well, radiation therapy is remarkably effective. We see reported response rates for stopping bleeding somewhere between, say, 88% and 95%.
That's incredible.
It really is. It's a crucial intervention for providing immediate relief and improving quality of life. This radiation can often be delivered in carefully targeted doses, sometimes in just one or a few sessions.
Are there other methods?
Yes, endoscopic interventions are common. That's where doctors use a scope to go in and directly treat the bleeding site, using methods like electrocoagulation or applying clips. These also have high initial success rates. Even newer chemotherapy approaches, like chronomodulated treatments, have shown significant success in reducing bleeding episodes. And another method is transcatheter arterial embolization, or TAE, which targets the specific blood vessels that are bleeding.
That's amazing progress in managing such a scary symptom. Obstruction must also be a common and really debilitating issue for patients. How is that typically managed?
Obstruction, yes, can severely impact a patient's ability to eat and their quality of life. Endoscopic stenting is a very common and effective approach.
How does that work?
It involves placing a small mesh tube, a stent, across the narrowed or blocked area to hold it open. This achieves high technical and clinical success rates, often allowing patients to start eating again the very same day. These stents usually stay open and functional for several months.
Are there surgical options too?
Yes, surgical interventions are also an option. These might include procedures like gastric partitioning, creating various bypasses like a gastrojejunostomy to route food around the blockage, or sometimes removing the obstructed section if possible. Surgery can also significantly improve solid food intake, often within a couple of weeks.
So when a patient and their team are weighing stenting versus surgery for obstruction,
Yeah.
what are the key trade-offs? What factors go into that decision?
That's a really vital discussion. Generally, stents lead to a much faster return to eating, often just one day, compared to maybe around 5 days after surgery. And stents tend to have fewer immediate post-procedure complications, something like 3% versus maybe 21% for surgery. But surgery might offer a longer period without symptoms recurring and potentially lower recurrence rates down the line. Stents, on the other hand, can sometimes have higher rates of late adverse events, like migrating or getting blocked again. So it's a very careful balancing act. It depends heavily on the individual patient's overall health, their prognosis, and what their priorities are: faster relief versus potentially longer-term control.
That makes sense. What about ascites, that uncomfortable fluid buildup in the abdomen?
Right, ascites causes that feeling of abdominal fullness or tension. For this, one cutting-edge approach is APEC. That stands for hyperthermic intraperitoneal chemoperfusion.
Sounds complex.
It basically involves circulating heated chemotherapy drugs directly within the abdominal cavity during surgery. When combined with aggressive cytoreduction that's surgically removing as much visible tumor as possible, HIPEC can drastically reduce the need for repeated fluid drainage, called paracentesis. In some studies, up to 70% of patients saw complete or partial remission of their ascites with certain IPEC approaches.
Are there non-surgical options for ascites?
Yes, standard intravenous chemotherapy, particularly regimens based on fluorouracil, also shows a clear benefit, improving ascites in a significant number of patients, maybe around 27–39%.
So moving beyond just treating these specific physical symptoms, how do these advanced interventions and palliative care overall really enhance a patient's quality of life in these advanced stages? It's more than just symptom control, right?
Absolutely. Quality of life measures in advanced cancer go far beyond just the physical. They encompass emotional well-being, social functioning, a patient's overall sense of health, and specific symptoms like pain, appetite loss, and fatigue. What's really encouraging is that patients receiving systemic therapies like chemotherapy often show no deterioration in their overall global health status.
Really?
Yes, and many actually experience improved social functioning and significant relief from eating difficulties and pain. This shows a clear benefit that goes beyond just shrinking the tumor.
What about hospice support services? What impact do they have?
Studies show that patients receiving hospice care report higher levels of improvement across a whole range of domains: physiological, psychological, emotional, social, and mental health. It provides comprehensive support, and even specific treatments for metastases like percutaneous liver ablation for liver mets have been shown in some studies to improve physical and functional well-being.
This really brings us to the cutting edge of advanced care: targeted therapies and immunotherapy. Let's dig into targeted therapies first. Precision medicine, right? Zeroing in on specific weaknesses in the cancer cells. Trastuzumab, approved back in 2010 for HER2 positive advanced gastric cancer, that was a game changer, wasn't it?
It really was a paradigm shift. Trastuzumab was the first targeted therapy approved for this type of stomach cancer. When it was added to standard first-line chemotherapy, it significantly extended overall survival. The median went from 11.1 months to 13.8 months.
Almost 3 months longer.
Exactly. And it improved progression-free survival, too. This wasn't just a small statistical blip. It represented a meaningful breakthrough for patients with HER2 positive disease.
And then ramucirumab came along in 2014. What did that bring to the table?
Ramucirumab was another significant step forward. It was approved initially as a single agent for patients whose cancer had progressed after their first round of chemotherapy. In that setting, it improved overall survival 5.2 months versus 3.8 months for placebo. And that made it the first targeted therapy approved as a standalone treatment for advanced gastric cancer.
And it's used in combination, too.
Yes. It was also approved in combination with paclitaxel, another chemo drug, for patients after first-line chemo failed. And that combination showed improved overall survival too, 9.6 months versus 7.4 months for paclitaxel alone. So it showed its value both alone and combined.
That's quite a bit of progress in a relatively short time frame. Are there other promising targeted therapy avenues being explored? Or have there been disappointments too?
Oh, definitely both. Many other targeted therapies are constantly being explored. Researchers are looking at different pathways, other HER2 inhibitors, drugs targeting EGFR, VEGF, the HGF-KIT pathway, MTOR inhibitors, a whole range.
What?
But the field is challenging. While some showed promise in early phase trials, many haven't delivered significant survival benefits in larger later stage studies, or sometimes they show increased side effects without enough added benefit. It really underscores how complex it is to tailor these treatments effectively to individual cancers. But the research is relentless, constantly pushing those boundaries.
And what about the latest in immunotherapy for stomach cancer? How is that field evolving?
Immunotherapy, particularly immune checkpoint blockade, is a major focus. The idea is to target proteins that act like brakes on the immune system's T cells, effectively releasing those brakes so the T cells can attack the cancer.
How's it working for stomach cancer?
It's interesting. While some immunotherapy drugs used as single agents haven't definitively shown superiority over traditional chemotherapy in advanced gastric cancer yet,
Okay.
what's really gaining traction are combination strategies. Using immunotherapy plus chemotherapy together, there's growing evidence suggesting that chemotherapy can actually modify the tumor microenvironment, potentially making the cancer cells more visible or more susceptible to the immunotherapy.
So the chemo primes the tumor for the immunotherapy.
That's the thinking, yeah. It's a really powerful insight and a very active, exciting area of ongoing research right now. Combining these approaches might be the key for many patients.
Well, this deep dive has really explored the intricate world of stomach cancer. From those subtle, easily missed initial symptoms all the way through to these really nuanced advancements in treatment and patient care. Understanding these details, especially the importance of listening to your body, being aware of those risk factors we discussed, it seems absolutely crucial for catching things earlier and improving outcomes. It's truly fascinating how much progress has been made, not just in fighting the cancer, but in understanding how to better support patients through prevention, through nutrition, and through these increasingly tailored therapies.
It really is remarkable, and it makes you think. Yeah, with the continuous evolution of precision medicine and how much more we're learning about cancer at the molecular level, how might future diagnostics further refine our ability to predict exactly which patients will respond best to which advanced therapies? Could we truly be ushering in an era of hyper-personalized cancer care?
And a provocative thought indeed. We want to thank our sponsor, Stonefly, again for making this deep dive possible. Stonefly offers truly robust solutions to safeguard your data and enhance your IT infrastructure. And you should definitely check out their cutting-edge 100 TB immutable and air-gapped SSO NAS. It's available right now for just $8,995. You can find more information at stonefly.com. Thank you so much for joining us on the deep dive.